Neurologic Institute, you can tell me the number, but it's probably close to 40. So that's a lot as it goes through. So Susie works when she's not hurting the children around. She works in epilepsy as well, as if that's not enough. So she's going to talk to us about anti-seizure medication management in the outpatient clinic. And I always love my interactions with Susie. I'm so glad she's able to join us. And then we'll take questions for both of them at the end of this.
All right. Thank you so much for having me today. My background is I have a master's in biology that I got from Youngstown State, and then I went on to do my master's in physician assistant studies. I graduated in 2011, and I've been part of the epilepsy department ever since, so I've been there about 14 years now. And this is so near and dear to my heart. I love the epilepsy patients, so talking to you about this is something that I really am passionate about. I don't have any disclosures. And so our outline is we're going to start with just basic medication choices, then move into levels, and then other surveillance screening and routine testing. All right, so this is a slide that just depicts the FDA approval of our anti-seizure medications over time. And if you look at the first column, there was less than 10 medications available for over 90 years, or for 90 years. So we were working with the basics, right? And then between 1990 and 2010, over 20 years, we had close to 10 medications that came out on the market. And then from 2010 to now, 14 years, we've had over 10 medications. So that just shows how much effort is going into treatment of seizures. And it's really exciting because we're just continuing to develop new ways to treat our patients. These medications are further broken down or thought about in generations. So we have first, second, and third generation ASMs. And as we move from first to third generation, we improve the pharmacokinetics, we decrease drug-drug interactions, and we typically have better tolerability with side effects. So, okay, well, there's over 25 medications that I can prescribe. Which one do I choose? And this is all things that go into the art of prescribing an anti-seizure medication. Just to highlight a couple, obviously seizure type is very important. What are the side effects that we might experience? Are they of reproductive age, as we just heard? What's the half-life? Can I reliably have someone take something 3 times a day, or do I need to move that to 2 or once a day for compliance? Do they have an epilepsy syndrome, specific medications for different syndromes? And then, what formulation or what's the cost? Do they have insurance? Can I get them on a brand medication? All right, so just a disclaimer, this is not the FDA approval. This is how I clinically practice, and there's a lot of primary literature that supports this thought process behind prescribing anti-seizure medications. So I'm gonna start on the right-hand side on generalized seizures. And so if we look at absence or staring seizures, ethosuximide, valproate, lamotrigine, and levetiracetam are the ones we think about starting in our childhood population is when we typically see those develop. Epileptic spasms, which many people know as infantile spasms, we use ACTH, vigabatrin, and prednisone steroids. And then our other more common, generalized seizure presentations, we usually, the first 5 medications on that list are the ones that we would typically start with. The ones below that are in parentheses are ones that if they don't tolerate those, they have side effects, they have allergies, we might kind of dabble in some other options or additional medications if they're having breakthrough seizures. Then moving to the left-hand side is focal seizures or partial epilepsy. You get a lot more options when we move into the focal realm. Many focal medications, as Liz mentioned, can potentially make generalized epilepsy worse. And so you have to be very careful starting a medication in someone that you don't have a good diagnosis of. But the nice thing is that focal seizures, you can use all of those meds plus all of the medications in the generalized category. So if I'm thinking of someone that does not have a diagnosis, I'm most likely sticking with these 5 medications. And so that's where that type of thought process comes from. And I feel like I had this like tattooed on my arm early on in my career so that we can make sure we start the right medicine on patients. All right, so moving on to serum levels. I think this is a very interesting topic. I know it varies what neurologists will decide, or practicing providers that practice in neurology will decide to do with anti-seizure medication levels. But basically, serum levels are we think of as like the brain concentration of the medicine. And they establish the ranges of these medication levels in clinical trials, where we think that the low end of the range is where there's more risk for breakthrough seizures, and as we move up the range to the high end, that's where we start to see the more significant adverse effects. So we know levels can vary for many reasons, and that can really be patient-specific or individualized, and also like in their genetics, how we clear the drugs. So I'm going to touch base on each one of these common indications to order some medication levels. The first is therapeutic drug monitoring. So we want to avoid pseudo-resistance. And pseudo-resistance is either I picked the wrong medication or I didn't dose it appropriately. So if you don't get it to the right dose and it's being underutilized, people can have breakthrough seizures. So we want to establish a therapeutic level. It can also be really helpful to determine if someone's not compliant with their medication. So I have someone that has a breakthrough seizure. They've had a great Keppra level of 25 in the past, and I get it back and it's less than 0.2, right? We get that. And I take my medicine. Well, studies show you're not taking it, or you're missing doses, or something's going wrong. So I think it's really helpful in that situation. Obviously, if they're reporting side effects, we're looking if they're on the high end of the range. And then in malabsorption and metabolism, if you have a suspected GI tract absorption issue, like I'm taking the medicine, it's not working, that's a good time. Or if they're like the fast metabolizers or slow metabolizers, that can be like genetic polymorphisms, or if they have impaired renal or hepatic clearance. Pregnancy. All right, so we just spent a long time on pregnancy, which was amazing. But in clinical practice, I want to get a level before they become pregnant. That helps me to understand so I get a baseline where they're doing great, because that's going to help me down the line decide, do I need to adjust that level to stay the same, right? I want to just get it to the same point that they are currently at doing well. That's because during pregnancy, we have increased seizure medication clearance, there's altered protein binding, and there's increased kidney blood flow. So those medicines are going through the system a lot faster, and so we often see those levels drop. So there's two main studies that are more recent that I feel like are good, studies to talk about at this point. There's the Empire study. That was published in 2018, and that's a double-blinded randomized study that looked at 4 medications. So lamotrigine, levetiracetam, carbamazepine, and phenytoin. And from their study, they said that there's really no evidence that there's a purpose to get a serum level versus just to watch clinical features. Now, clinically, I disagree with that. I feel like I would not be doing my patients a service if I'm waiting for them to call me with a seizure to increase their medication. And so what Liz was talking about, many of our medicines we're either getting every trimester for the ones that typically don't, get too affected by pregnancy, versus lamotrigine, I'm getting monthly levels and I'm proactively increasing. And often I'm doubling the dose by the time they deliver. Okay, that's how significant, as you saw in the Monid study, that lamotrigine, decreases 50%. So you have some women on 800 milligrams of Lamictal by the time they're delivering, and then very quickly after, within a week or two, we are bumping that dose down because they will get toxic once that all clears. So the Monid study, Liz went into detail about that. This was it was a well-anticipated and wonderfully written study with multiple aims to show, it's wonderful. I highly recommend reading it. For this purpose, it was, just showed all those medication levels that are decreasing during pregnancy, but it also showed wonderful outcomes of women who are comparing on medications for epilepsy and not on medications, and very similar outcomes, which is good to make our patients feel a little better about taking their medicine. All right, so question number 1. In the United States, how long does a person with epilepsy need to be seizure-free to resume driving privileges? A, federal law requires 6 months, state law requires 6 months, federal law requires 1 year, state laws vary. All right, so wonderful. It is, state laws vary. And just to break that down a little bit, you know, we're not clinically trained to be providers in traffic medicine. I don't know how many people are that in the country, but as neurologists or practicing in neurology, we're asked to clear to drive, right? And so there's that balance between what's, you know, patient safety and what's individual independence for a patient. And we have to balance that. And we're not regulated by the federal government, we're regulated by the state you practice in. So it's anywhere, it can be either by, you know, the time, so 3 to 12 months is typical, versus some have adopted more of a flexible regulation where it's the provider's decision what they allow the patient to do. So this is a typical precautions that I would give a newly diagnosed patient, you know, what they should avoid. In that, I always put that they need to be cleared by a neurologist to drive. If they have active epilepsy, they should not be driving, and that the state laws vary. So to refer, this is the website that we can utilize, and this is what it looks like. So you can just get information on one state, or you can compare states to see what your laws are. Some states are reporting states. Ohio's not a reporting state, but Ohio, we need to do a BMV form. So many states have these forms you have to fill out on a regular basis for patients with epilepsy. The highlighted part is what the patient would fill out. Then they get it to the office. I would mark that they have a neurologic disease, that they have epilepsy since this year, that their last seizure was this time. And then the level that I draw is because of question number 4. If medication's prescribed, are they compliant? So that's my way of saying, I mean, I could talk to anyone and they're gonna report, oh, I take my medicine, but as we know, that's not always the case. So I get a level, I show it's in the normal range, and I check that box that they're compliant. All right, brand to generic. So there is a concern that the standard bioequivalence range can be variable when you move to a generic medication. And it appears that sometimes it's a little too broad for seizure medications. Now, evidence shows, studies show that really there is no associated risk in a loss of seizure control if you move to a generic. But if you ask a patient to switch to generic when they've been on a brand medication for 10 years, they are going to be anxious and they're going to be stressed and they're going to come and be very panicked about it. And we know stress can lead to seizures. So it's just not worth it to me. So, you know, it's also not worth them spending $4,000 on a brand out of pocket. So I get a level when they're on the brand, and I tell them we're gonna get a level 2 weeks after you transition, 1 or 2 weeks. And if it looks about the same, we're good to go. And that gives them more, you know, it makes them feel better. If there is a change, then we have an active discussion. What do we need to do about that? Hormone contraception therapy was also something Liz has discussed. So we know that enzyme-inducing seizure meds can decrease hormonal contraception. If they are on one of those inducers, you should be recommending 2 forms of birth control. So if they're on oral contraceptive, recommend a condom also. But in this case, for levels, we know that it can affect the lamotrigine level, and we have talked about that part. All right, so overall things to consider. So just to play devil's advocate, some studies show that doing systematic drug levels doesn't bring tangible benefits. Sometimes they have this very wide therapeutic range. So what am I targeting? I don't know, like, am I targeting a 2 or a 45? Not all labs, not all hospitals have medication levels readily available. They're send-out labs. Is that helpful to me if I can't get them quickly? Sometimes, like, focusing on an individual reference of a patient might be better in these newer meds that we really don't have a good grasp of what's the best level to be at. But if anything comes out of my talk, treat the patient, not the level, okay? That's another tattoo that I got over time. So, how many times have I had someone go to a local doctor, they get their medication levels, thanks for the help, I love it, but the Dilantin comes back at 21, and the phenytoin, and they're at 21, it's right outside the 20 range, and they say, oh, you're too high, and they drop their dose, and I'm like, and they come back and they're like, I had a seizure, and I'm like, well, yeah, you were not having side effects, and you weren't seizing, why did they touch your medicine? They said it was too high. You have to use your clinical judgment on this and do what's best for the patient and just monitor the things that matter. All right, in patients who are taking an anti-seizure medication with hepatic enzyme-inducing or inhibiting actions, which of the following tests should be recommended and routinely followed? A, liver enzyme blood levels, B, vitamin D blood levels, C, DEXA bone scan, D, all of the above, E, none of the above. Moving around. All right, so the answer is actually all of the above. If you've got the resources to do so, I would recommend it, and I'll explain why in the next few slides. All right, so this is just a nice graph. If you get the slides from this talk, I'm not going to go through this. I'm going to touch on each of them, but these are great tests that you should think about if you have someone on long-term anti-seizure medication. So for vitamin D deficiency, if you're on a long-term anti-seizure med, it can impact vitamin D metabolism. So the longer you're on it, the lower the vitamin D could potentially go. So I'm, saying, go do some outdoor activities, eat your vitamin D and calcium-rich foods. And many of my older anti-seizure medicines, I'm just telling them start a vitamin D calcium supplement to make sure you're keeping up with that for long-term effects. Because similarly, bone health, right? So older anti-seizure medications, we know, and likely newer, studies aren't fully out yet on this, have a negative effect on the bone mineral density and also bone metabolism. And so we know that persons with epilepsy have a higher fracture prevalence than the general population. So I typically, not for my newer seizure meds yet, and we'll see in the future if I do that too, but if someone's on carbamazepine, phenytoin, valproate for 10 years or more, I'm getting a DEXA scan at that point, and then every 4 to 5 years after that. If it were to come back and show osteopenia or osteoporosis, I'm teaming up with the PCP. I say, let's get some help. And then also, do we want to think about a transition to a newer generation anti-seizure medication at that point? Okay, hematologic reactions. So there are black box warnings about adverse effects from anti-seizure medications. To name a few, thrombocytopenia, neutropenia, aplastic anemia with felbamate, and bone marrow failure. Felbamate was taken off the market. It was like one of those meds that came in hot and everyone was using it, and then they saw a couple cases of aplastic anemia, took it off the market. It's back out there, but you have to get some monitoring. So if they're on, the medicines listed on that chart, typically I want a CBC at least yearly to check in and make sure there's no changes. For felbamate, we're also getting a retic count at regular intervals. And then liver and kidney clearance. So, our older generation meds are a little harsher on the liver. Some of the medicines are metabolized through the kidneys. Not all directly affect the liver or kidneys, but if they're being metabolized through it, we do want to keep an eye on things. A review of over 2,000 drug-induced liver injury reports to the FDA in that time frame of about 2 years or so, or 3 years. It showed that the newer generation seizure meds were not significantly associated with that liver injury. So that's a good thing, right? It shows that newer generations are doing better. But many of our patients are on the older ones, so please get a CMP to check in at least yearly. Hyponatremia. So this is specifically for our medications that are sodium channel blockers. The most common culprit for this is oxcarbazepine, but also carbamazepine, I think about this. So a risk factor for developing hyponatremia is the age, gender, dosage, and if it's combined with other medications. Studies have shown that the longer you're on oxcarbazepine, there's a higher incidence of hyponatremia. So I'm typically getting a CMP at least yearly for my oxcarbazepine patients. And it's okay if they get a little below the normal range and they're steady, right? If I'm at 134 and I'm staying steady, I'm totally fine with that. But if they develop symptoms or that level continues to drop, I'm getting new levels if they have symptoms of hyponatremia, but, do we need to get them to primary care to help with this supplementation of sodium or, watching fluid restriction, or do they just need to change to another medication? I've unfortunately seen people in the low 120s walking around clinics, so something to keep an eye on. And then hyperammonemia. So this is directly with valproate, which Liz had mentioned in her talk. It could be an acute thing, so like she was talking about in the hospital in like a loading dose type of setting, but also chronically on Depakote you can see changes in ammonia. This is not something I'm getting regularly. I don't get an ammonia once a year. But if they're coming in with symptoms of irritability, fatigue, behavior changes, I get ammonia at that point and then I monitor it because it is common, and ammonia crosses the blood-brain barrier and it can it enters astrocytes, and then it can cause this neurotoxicity. So it's important to keep an eye on, or a thought process. And then this is my last slide, HLA genotyping, the risk of, I know that was a close call, Dr. Stevens. I know he's going to kick me off, but I just have one last slide. So this is something that I don't think a lot of people think about. So HLA genotyping, this is specific for Asian ancestry. If there's a 15% population is positive for this HLA allele. And if they have this increased hypersensitivity to dermatologic reactions, which is kind of a high number. So we can get things like Stevens-Johnson's and Dress syndrome. So if you have someone that you're thinking about starting on carbamazepine or oxcarbazepine and they have Asian ancestry, really should think about getting this screening ahead of time. I think that's it.
One question, go to the mic.